Good day, everyone. Welcome to our discussion about cardiovascular disorders, particularly arrhythmia and conduction problems. So, join me. Once again, I'm Dr. Judith Sugay. So, for the learning outcomes, at the end of this discussion, the students will be able to define key terms. Okay, discuss the cardiac conduction system, explain arrhythmia and its types, explain as well the components of the normal electrocardiogram, discuss the electrocardiographic criteria, causes, and management of arrhythmias. Utilize the nursing process as framework, okay, for care of patient with arrhythmia and electroconduction disturbances. Okay, so here are some key terms that we need to understand more, okay, as we go along with the topic. So we have defibrillation. This refers to electrical current given to stop an arrhythmia, which is not synchronized with the patient's QRS complex. Depolarization is the process by which cardiac muscles change from a more negatively charged to a more positively charged intracellular state. On the contrary, repolarization is a process by which cardiac muscle cells return to a more negatively charged intracellular condition, which is also referred to as their resting state. For the cardiac conduction system, SA node, okay, is also referred to as the sinoatrial node. So, at the conjunction of the superior vena cava, if you can recall, okay, and also high lateral atrium is a cluster cell or cluster cells that generates the initial electrical impulse of each normal heartbeat. And that's what we call the sinoatrial node, or we refer to this as sinus node. So this electrical discharge, again, of these pacemaker cells stimulate the adjacent cells, leading to stimulation of successive regions of the heart in an orderly sequence. On the other hand, impulses are transmitted through the atria, okay, to the atrioventricular node, or we call that the AV node. Okay, so this is via the preferentially conducting internodal tracts and unspecialized atrial myocytes. On the other hand, this AV node is located on the right side of the interatrial septum, and it has a slow conduction velocity. So, given this one, thus it will delay the impulse transmission. Okay, so the heart rate now is dependent and is modulated by autonomic tone in circulating catecholamines to maximize the cardiac output. Okay, so let's have the cardiac conduction system as, again, continuation. We have the bundle of His. Okay, the bundle of His is the continuation of the AV node. Remember the previous slide, okay? It enters the top of the interventricular septum. Alright, so as you can see here, this is the illustration. Alright, if this is the bundle of His, there it enters the it enters here, okay, the top of the interventricular septum, and then it now bifurcates, okay, so into the right and into the left there. Okay, so the right bundle branch conducts impulses to the anterior and apical endocardial regions of the right ventricle. Okay, so here we can see that one. Whereas the left bundle branch fans out, alright, okay, on the side of the interventricular septum. We can also notice the anterior and posterior part. Okay, so that portion stimulate the left side of the interventricular septum, which is the first part of the ventricles to be electrically activated. Okay, so again, the interventricular septum depolarizes left to right, followed by near simultaneous activation of both ventricles. Okay, so here on the bottom part. All right. And then again, there'll be this is again for both ventricles from the endocardial surface through the ventricular walls to the epicardial surface of the heart. Okay, so what do we mean now by arrhythmia? Arrhythmia is a disorder of the formation of conduction or both of the electrical impulse within the heart. So, this can cause disturbances of the heart, particularly on its heart rate, okay, the heart rhythm. Okay, remember when we say irregular, regular, okay, or even both, okay. Another one is that we have the hemodynamic effect. So, for the hemodynamic effect, there's going to be change in the conduction system, okay, again, because of the change in the pumping action of the heart, which will then can cause decrease in the blood pressure, okay, and can later on decrease the cardiac output of the client. Okay, if when we say decrease in the cardiac output of the client may experience lightheadedness, okay, or loss of consciousness, even worse, okay, there might be sudden cardiac death. So, what causes arrhythmia? Actually, there are several causes of arrhythmia. We only have here the most common causes of rhythm disorders. So, either direct damage or through the dilation of the heart chambers that alters the conduction system. Okay, so remember again, when there is ischemia, there is a decreased blood flow, just like that of coronary artery disease, hypertension, diabetes, hyperthyroidism. And given that one, so there'll be particularly, okay, the causing bradycardia. Okay, so damage as a node, again, you can notice here that it will cause bradycardia, and bradycardia is less than 60 beats per minute. On the other hand, here you also notice one of the causes is having irritable atrial myocytes. Okay, so if the atrial myocytes become irritable and depolarize independently and sporadically, the signals are variable through the AV nodes, leading to random, irregularly regular heart rate of the atrial fibrillation. So, when we say irregular, irregularly irregular, meaning it has no functional atrial contraction. So, if, again, another condition is if the AV node is dysfunctional, okay, that's another cause, there will be varying degrees of heart blocking, okay. So, it could range from simple prolongation of the PR interval on ECG, that's going to be first block. Other causes would be intermittent transmission of the signal, and also the complete failure, which is again the third degree heart block. Okay, so these are common causes. So, moving on, a while ago we've discussed the PR interval, also some depolarization, and so many more. Let's now find more about those through ECG or electrocardiogram. So the electrocardiogram refers to the electrical impulse that travels through the heart that can be viewed by means of electrocardiography. And the end product is ECG or electrocardiogram. Okay, so specific waveforms on the screen of a cardiac monitor. I am not sure if you've seen one, but there is a monitor, and there is a paper. Okay, that's it's fitted with some strips. Okay, and that's going to be used for measuring the ECG. Okay, so here actually is an example of that one. Okay, so let's discuss further. What do we mean by waves, complexes, intervals? Alright, so a while ago, we've presented a very simple strip, right? And you've only seen some lines, up and down lines. It's on a graphic paper. So let's take a look at it closer. So we have here the P wave. Okay, so when we say P wave, this is actually electrical impulse starting in the SA node. It represents the atrial depolarization. Okay, again, when we say atrial depolarization, it's like the squeezing effect. Okay, when in terms of its measurement, there is like here normally 2.5 millimeters or less in height, and it only lasts for 0.11 seconds. So let's move on to the complexes. So let's see. We now have here the QRS complex. QRS complex, okay, basically represents ventricular depolarization, okay, or the squeezing of the ventricles. So normally, it takes less than 0.4 seconds in duration and less than 25% of the R wave amplitude, okay. So for the QRS complex, again, here we have 0.12 seconds in duration. Okay, so the Q wave is the first negative deflection after the P wave. So this is what you can see. And as I would just like to reiterate that the Q wave takes normally, okay, so this one, the Q wave takes normally less than 0.4 seconds in duration. Alright? So let's now have the R, okay, R and S, okay. The R wave is the first positive deflection after the P wave, and S wave is the first negative, okay, deflection after the R wave. If, for example, you've seen some strips that's written or printed with small letters, so we can say that a wave is less than 5 millimeters in height, while it's bigger when it's capital letters. Okay? So, again, the QRS complex normally takes less than 0.12 seconds in duration. So, we now have here the T wave. T wave represents ventricular repolarization. Again, when we say repolarization, it is when the cells regain charge. It is the time when filling of the ventricles happen. So, sometimes, of course, it will also be referred to the resting status. Okay? So, obviously, the T wave, okay, so this is the T wave, follows the QRS complex, right? And then, atrial repolarization happens but not visible on ECG because it happens at the same time as ventricular depolarization as such of the QRS complex. Now, we have the U wave. So, U wave is thought to be to represent repolarization of the Purkinje fibers. Although this wave is rare, which we don't have here, okay, sometimes it appears in patients with hypokalemia or patients with low potassium level, patients with hypertension or heart disease. So, if present, the U wave follows, of course, the T wave and usually smaller than the P wave. So, there, it's going to be smaller than the P wave. Okay, let's now discuss the intervals. Alright, so we have intervals here. Okay, so the PR interval is measured from the beginning of the P wave to the beginning of the QRS complex. it actually represents the time needed for the sinus simulation, atrial depolarization, and conduction as well. So for adults, the normal range is between 0.12 to 0.20 seconds in duration. QT interval represents the total time for ventricular depolarization and repolarization. It is measured from the beginning of the QRS complex to the end of T wave. Okay, there is a specific calculation actually, since there is interval variation within which again depending on the age, heart rate, gender. So however, QT interval is usually 0.32 to 0.40 duration, okay? If the heart rate is 65 beats per minute, okay? TP interval, okay? So this is the TP interval. So this is measured from the end of the T wave, okay, to the beginning of the next P wave. It is, as you can see, an isoelectric line. So when there's no electrical activity, when there's no electrical activity detected, the line on the graph remains flat, and that's what we refer to as isoelectric line. Okay, let's now have the PP interval. Okay, so it's measured from the beginning of one P wave. It's from the beginning of one P wave, okay, to the next to the beginning of the next P wave. That's why it's PP. Okay, so it's PP. This is used to determine the atrial rate and rhythm. Okay, next is the RR interval. RR interval, we're done here with the so we also have some here, okay, PR and so on, but let's focus on the RR interval. So it's measured from the QRS complex to the next QRS complex. Okay, so there we go, and then here, and then another one here and there. Okay, so it's actually used to determine ventricular rate and rhythm. Alright, so we're done with the waves, complexes, and intervals. Let's now have the placement of the electrodes. Okay, so I don't know if you have experienced having ECG or you've observed ECG placement from your relatives or your loved ones. Okay, but this is where electrodes will be placed. So you have here, we have the electrode name, RA. Okay, so RA on the right arm. So right arm, left arm, okay. You also have the, you can also have the right leg. Okay, let's assume we have that one here, and then the left leg. Okay, and then we also have here V1. Okay, V1 is between the fourth and fifth ribs, okay, to the right of the sternum. So this was the sternum, and then V2 we have between still between fourth and fifth to the left. This one is to the left of the sternum. V3 is the leads, okay, between V2 and V4. Okay, so V4 is here, we have between fifth and sixth ribs in the mid-clavicular line. Okay, so there you go. Alright, and then V5 in the left axillary. Okay, so here, left axillary line, horizontal even with V4. Okay, and lastly, we have V6 in the mid-axillary line Okay, this one's the axilla. Mid of that is the V6. Horizontally even with V4 and V5. There. Okay. So, we have here the characteristics of normal sinus rhythm. So, the ventricular and atrial rate, okay, should be between 60 to 100 beats per minute in the adult, with its ventricular and atrial rhythm at regular pace. Okay, so P wave is normal and consistent in shape. It's always in front of the QRS. Okay, so that's before the QRS. I hope you remember. PR is consistently between 0.12 and 0.2 seconds, having as well QRS, the ratio between P and QRS as to 1:1. Okay, so that is the normal sinus rhythm, and a normal sinus rhythm will show like this in the ECG strip. Okay. What are the types of arrhythmia? We have sinus node, atrial node, ventricular node. Okay, so for the sinus node, we have sinus bradycardia. Sinus bradycardia occurs when the sinus atrial node creates an impulse at a slower than normal. Okay, slower than normal normal rate. So that's less than 60 beats per minute. So it causes the following, or again, it is because of the following, probably. Okay, one of these, okay, can cause that one. So we have lower metabolic needs. Example, when an individual is asleep. Okay, also evident among athletes who are active in exercising. Okay, so what else? Hypothyroidism, unknown sinus node dysfunction as well. So there is sinus bradycardia. Vagal stimulation, so when there's an act of vomiting, suctioning, severe pain. Okay, another one, we have intake of some medications like that of calcium channel blockers, beta blockers. This can of course have an effect on the blood pressure, cardiac output. Okay, and then those with coronary artery disease, so that's what we mean by CAD. Okay, example, patients diagnosed with myocardial infarction. Okay, so in sinus bradycardia, we can say that the ventricular and atrial rate, okay, could be 60 beats per minute in an adult, or less of that. And then ventricular and atrial rhythm is still regular though, but the QRS usually normal, but sometimes regularly abnormal. Okay, P wave is normal and consistent. So the ratio is still 1:1. Now, what do we do with this kind of condition? So, medical management includes, okay, again, we have to determine what's causing the symptoms. For clinical instability, or again, when we say clinical instability, the client here experiences acute alteration in mental status. What else? Chest discomfort or hypotension. So, here, the client or patient is given with 0.5 milligrams of atropine. Okay, so slowly, again, so this one, there's rapid administration via IV bolus every 3, okay, so every 3 to 5 minutes until the maximum dose of 3 milligrams is given. Okay, if still unresponsive despite the administration of atropine, dopamine or isoproterenol or epinephrine can be given. So, This one, dopamine, again, is the second line, okay? This is the second line drug for symptomatic bradycardia if atropine is not effective. And then also epinephrine is has equal effect to dopamine, okay, as well as the isoproterenol. So on the other hand, we have here sinus node arrhythmia, particularly tachycardia. Okay, so this happens when the sinus node creates an impulse at a faster than normal rate. So that's more than 100 beats per minute. Okay, so it's caused by either physiologic or psychologic stress, medications, or stimulants. So under physiologic or psychologic stress, we have acute blood loss, anemia, client is in pain or shock. Okay, medications such as catecholamines, aminophylline, okay, atropine, or illicit drugs can stimulate the sympathetic response, and of course, it will increase again the heart rate of the client. So stimulants, as you can observe after taking caffeine even by yourself, isn't it that you get more like hyper energetic, right? So just imagine if an individual with abnormalities taking caffeine or nicotine stimulants, okay? For medical management, still we have to find out what causes the sinus tachycardia. Okay, for vagal maneuvers, okay, carotid sinus massage, gagging, bearing down with closed glottis, okay, so these are the management. So what else for cardioversion? We have, if tachycardia is persistent and causes hemodynamic instability, or the mental alteration status, chest discomfort. Okay, electrical current is given in synchrony with QRS complex to stop arrhythmia. And there's of course administration of adenosine. Okay, so adenosine is the drug of choice for paroxysmal tachycardia, PSVT. Again, it's used in advanced life cardiac support. Okay, so alright. Next, we have atrial fibrillation. Atrial fibrillation originate from from foci with the atria and not the sinoatrial node. So it results from abnormal impulse formation that happens when structural or electrophysiological abnormalities alter the atrial musculature and intrinsic cardio-autonomic nervous system. So, what are these risk factors? Probably it could be because of increasing age, okay? Because as we have mentioned prior during the assessment, the structure of the heart, okay, deteriorates, or there's going to have some dysfunction as an individual ages. So another one, there are also illnesses or diseases such as hypertension and diabetes. And of course, unhealthy lifestyles such as poor stress management, smoking, and sedentary lifestyle. And another one, it is very important as well for you to ask any members of the family, okay, that has cardiovascular disorder or cardiovascular disease. And if and when the patient has underwent cardiothoracic surgery like that of CABG or even stent placement or angioplasty. So what's important is yeah, we have to administer thrombotic medications. Okay, so this one will prevent embolic situations or events. Again, because these thrombotic medications acts as a blood thinner, and they will prevent embolism. Okay, so next, we have to control the ventricular rate of response. Okay, if less than 80 beats per minute, then there's beta blocker, prevents the sympathetic nervous system from increasing the heart rate activity, and calcium channel blockers. Okay, so this decreases the cardiac contractility. Okay, if that's being decreased, then it will prevent tachycardia. Okay, so we also have here ventricular fibrillation. This is the most common arrhythmia in patients with cardiac arrest. Okay, there is some rapid ventricular rhythm. Okay, as what you can see there, rapid ventricular fibrillation. Okay, or rhythm that causes ineffective quivering of the ventricles. So there's no atrial activity seen on ECG. Then what could be its signs and symptoms? So ventricular fibrillation causes unconsciousness in seconds. Okay, with that, you will observe absence of audible heartbeat, palpable pulse, and respiration. If untreated, the person usually has a brief seizure and then becomes limp and unresponsive. People develop irreversible brain damage after around 5 minutes because oxygen, again, no longer reaches the brain. And with that, if it takes longer, then death follows. Okay, then what could be the medical management? So, cardiopulmonary resuscitation or CPR. Again, it's important that the doctor also would would order, okay, administration of epinephrine to facilitate the return of the spontaneous pulse. Okay, so usually epinephrine dose, okay, is not based on body weight, but a standard of 1 milligrams of epinephrine is being used in surgical operating rooms for intracardiac injections. So that's according to American Heart Association. Okay, so having learned those, let's now visualize ourselves, okay, facing our clients. So we now conduct nursing assessment. So what do we assess for? As mentioned a while ago, you need to conduct health history. Okay, so for the assessment, so again, you have to conduct interview. You have to, one of the questions would be, okay, you ask any occurrence of decreased cardiac output, any experience of having lightheadedness, easy fatigability or fatigue per se, syncope, chest discomfort, change in mental status as well. Okay, and is there any medication, be it like prescribed or not? Then identify those. Okay, and then as you conduct the physical examination, you have to check the color of the skin. And then you have to palpate as well. Is it cool? Okay, is the client sweaty? Okay, clammy? And then also check for signs of fluid retention as you auscultate, okay, for any crackles, wheezes, and even when you auscultate for heart sounds, okay, have you like heard of extra heart sounds? So that could be an indication of murmurs. So you need to document those assessments. And then few of the nursing diagnoses that we can come up with based on, of course, the cues, okay, relevant cues of the client. So again, these are not cast to stone diagnoses, okay. So you will be the one to determine depending on the result of the assessment. So we have, for example, impaired cardiac output related to altered heart rate. Again, you have to check what is the heart rate of your patient. So it could be like there's anxiety related to fear of the unknown, unknown outcome of altered health condition, lack of knowledge about arrhythmia, and its treatment. Then one of the goals could be after nursing intervention, the patient will be able to maintain a normal cardiac output as evidenced by normal pulse pressure and decreasing occurrence of arrhythmia. Some of the nursing interventions are here. Okay, so you monitor the vital signs of the patient. That includes pulse rate, respiratory rate, blood pressure. Okay, evaluate the presence of arrhythmia through conducting, of course, interview and checking as well the result of the physical examination. And then, as ordered, you are to obtain 12 leads ECG as ordered, and any findings, again, should be collaborated, referred accordingly to the physician. So, for the evaluation, again, for best outcomes, it is again expected, or this is what you would as much like the patient to have, right? Okay, to have an outcome that the patient maintains normal cardiac output as evidenced by normal heart rate, blood pressure, okay, respiratory rate, and level of consciousness. The client also experiences reduced anxiety. Alright, so here are the references that I used, and you can also read on it to have further knowledge about the topic. So, that's it for our discussion about the about arrhythmia and conduction problems. Should you have any questions, I'm just here for you to be clarified, and I hope to see you and let's have a productive discussion about this one. So thank you, maraming salamat.